Hello, my name is Dr. Goldberg, and I will be narrating the following two videos that demonstrate my silicone oil aspirator being used to remove silicone oil during cataract surgery in patients who develop visually significant cataracts after undergoing complicated retinal detachment repair using silicone oil tamponade. My first case shows a large amount of emulsified oil layered up against the corneal endothelium in the anterior chamber in a supine patient. This occurs because a varying amount of oil escapes around the zonules and ends up in the anterior chamber after the silicone oil is placed in the vitreous cavity to repair the complicated retinal detachment. The emulsified oil is normally observed layered at the top of the anterior chamber when the patient is examined at the slit lamp. The oil is removed first by making a side port incision and then irrigating out as much as possible with a cannula connected to a syringe with balanced salt solution. The remaining oil bubbles can be cleared from the anterior chamber by displacing them with viscoelastic injected into the anterior chamber through the side port incision. In this case, I'm using Viscoat. This case has a poorly dilating pupil due to 360-degree posterior synechii, which are partially broken by a standard irrigating cannula. Here I am breaking the synechii using the cannula. Next, the temporal cataract wound is made with a standard keratome. I recommend a 3 mm opening to allow easier egress of the oil around my silicone oil aspirator cannula that will also stent the wound open and be depicted later in this video. Next, I am further enlarging the pupil by separating the synechii through the temporal cataract wound with the cannula. Adequate dilation of the pupil is obtained using a Beeler pupil dilator. Since the view is compromised by a dense cataract, trypan blue dye is used to stain the anterior capsule. Initially, balanced salt solution is injected through the side port incision to partially remove the dye. Then viscoelastic is added to clear the dye from the anterior chamber and also viscodilate the pupil. The viscoelastic provides nice dilation of the pupil. After the anterior capsulorhexis is performed, which is challenging due to the synechii, hydrodissection is accomplished and then phacoemulsification is completed. A slow and steady technique is used to perform the capsulorhexis with the synechii in place. I have included edited highlights of my cataract surgery technique. Next, and perhaps the most difficult part of the surgery, the posterior capsulorhexis is performed. I have a few tips to offer to improve performance of the capsulorhexis. First and foremost, do not overfill the anterior chamber, but keep the chamber only partially formed with the posterior capsule somewhat flaccid. Do not deepen the anterior chamber and fill the capsule like you would for intraocular lens implantation, or you risk running the anterior capsulorhexis out to the periphery where it will be impossible to control. Another tip is to use high magnification. And finally, while not absolutely necessary, I usually stain the posterior capsule with trypan blue dye. In this case, there is residual dye from the anterior capsule staining, so further trypan blue dye is unnecessary. To initiate the posterior capsule tear, I either use a regular cystotome as in this case, or a straight 25 gauge needle as depicted in my next video. When you make the initial tear, you will note that oil bulges forward, being held back by the viscoelastic. Careful enlargement with frequent regrasping is required to complete the posterior capsulorhexis. I attempt to make a 4 mm opening so that I can implant my regular one-piece acrylic posterior chamber intraocular lens, which happens to be an Envista by Bausch & Lomb, in the bag in most cases, without having to resort to a sulcus fixated 6.5 mm optic 3-piece lens. In this case, there is a posterior subcapsular opacity adherent to the posterior capsule near the end of the capsulorhexis that was not allowing me to tear through the area of the remaining posterior subcapsular attachment. Therefore, to remove the final piece of the posterior capsule and complete the capsulorhexis, I used a pair of small scissors to incise the final capsule attachment and make an oval capsulorhexis that remains intact throughout the entire case. Next, a self-retaining 23 gauge anterior chamber maintainer is placed through the side port incision, and irrigation is started through the anterior chamber maintainer while I place my silicone oil aspirator through the temporal cataract wound, which acts as a stent to allow the oil to exit through the incision. Most of the oil initially is irrigated out of the eye, but I also perform aspiration through the entire procedure, as that additionally removes the portion of the oil. It may take 5 to 15 minutes to irrigate the oil from the eye, so patience is required. In this particular case, there is a residual bubble of oil that cannot be irrigated out of the eye and remains deep in the vitreous cavity. The edge of the bubble is seen in the upper half of the pupil as shown by the arrows. To remove this bubble, I place my aspirator against its deep edge in the eye and aspirate on full suction in order to remove the residual oil. It may take another 5 minutes to remove the rest of the oil. My cannula can be placed just out of view of the pupil edge safely as long as it is placed in a downward position, since the aspirator opens bevel down. To remove all the oil, you may need to intermittently stop side port irrigation, since it tends to push the remaining oil bubble out of view into the periphery. Careful aspiration through the cannula with intermittent infusion through the anterior chamber maintainer will remove the remaining oil bubble. The video shows the bubble getting progressively smaller until it is not evident in the superior part of the pupil. The next step, which is not shown, was to successfully implant a one-piece posterior chamber lens in the capsular bag. The Goldberg Silicone Oil Aspirator Cannula is available through Rhine Medical. Thanks for watching my presentation. This is Dr. Lawrence Goldberg from St. Petersburg, Florida.